Cure for Pain is an integrative rheumatology clinic in Mumbai, India. Over 9 years and 13,000 patients, we have developed a protocol that achieves above 90% remission in compliant rheumatoid arthritis patients within 3 to 5 months. In this video, we lay out all 7 pillars of that protocol in full detail. The honest month-by-month clinical timeline of what to expect and when, and exactly why this cannot be attempted without proper medical supervision. Our protocol has 7 pillars, not 1 or 2. All 7 are necessary. This is not alternative medicine. This is integrative medicine. We address what conventional therapy misses while respecting what conventional therapy does well. Pillar 1 is comprehensive metabolic assessment. Before starting any treatment modifications, we assess the full metabolic picture. Immune markers include RF, anti-CCP, ANA panel, CRP, ESR, immunoglobulin levels, and complement C3 and C4. Nutritional markers include 25OH, vitamin D, intact PTH, magnesium, preferably RBC, not serum, vitamin K, B12, folate, methyl malonic acid, homocysteine, iron studies including iron, TIBC, ferritin, and transferrin saturation, plus zinc, selenium, and copper. Metabolic markers include fasting glucose, fasting insulin, HOMA-IR, HbA1c, lipid panel with advanced markers, liver function tests, and kidney function with cystatin C. Thyroid function includes TSH, free T4, free T3, reverse T3, anti-TPO and anti-thyroglobulin antibodies, and thyroid ultrasound if antibodies are positive. Gut and infection markers include comprehensive stool analysis, SIBO breath test if indicated, calprotectin, zonulin, candida antibodies, and EBV and CMV serology if history suggests. A fuller panel may be needed based on clinical presentation and comorbidities. This baseline assessment identifies all the dysfunctions that need addressing. Without this comprehensive picture, you're flying blind. You don't know which cofactors are depleted. You don't know how severe the vitamin D resistance is. You don't know what infections are present. You don't know where the metabolic dysfunction lies. With this comprehensive picture, you have a roadmap. Every intervention becomes targeted. Every adjustment becomes measurable. Every outcome becomes verifiable. This is the difference between guessing and knowing. This is the foundation of precision medicine for autoimmune disease. Pillar 2 is vitamin D and cofactor optimization. This is the cornerstone of our protocol, not a supplement added to conventional therapy, the cornerstone. Step 1. Correct cofactor deficiencies first. Magnesium is essential for every step of vitamin D metabolism. Without adequate magnesium, high-dose vitamin D cannot work and may even cause problems. We optimize magnesium using appropriate formulations. The dosage is not a standard amount. It's correlated to the vitamin D dosage we'll be using. Vitamin K2 ensures calcium goes into bone rather than soft tissues, critical for safety at therapeutic vitamin D levels. B vitamins support methylation and immune regulation. All cofactors are dosed in proportion to the therapeutic vitamin D protocol, not as standalone supplements with generic dosing. Step 2. Therapeutic vitamin D loading and maintenance. Our target for established RA is 25OH vitamin D levels of 120 to 180 nanograms per milliliter. This is where remission is achieved and sustained. We use a loading protocol initially to rapidly correct severe deficiency and overcome vitamin D resistance. Maintenance dosing is then individualized based on body weight, severity of disease, degree of VDR resistance, and presence of comorbidities. Some patients require higher sustained doses. Some can maintain remission on lower doses once immune regulation is restored. This is determined by monitoring both laboratory values and clinical response. Step 3. Close monitoring for safety. We monitor ionized calcium and intact parathyroid hormone every 3 months, especially in the first year. Once remission is achieved, our clinical data shows this typically occurs in most RA cases within 8 to 10 months, or in cases with compliance challenges, 12 months. We continue monitoring but may extend intervals based on stability. We also track the full metabolic panel, inflammatory markers, disease activity scores, and adjust the protocol based on comprehensive assessment, not just vitamin D levels. This is precision medicine, not guesswork. Step 4. Integration and medication tapering. Here's where our approach differs fundamentally from conventional management. We don't keep patients on DMARDs, biologics, and steroids indefinitely while adding vitamin D as a supplement. We use vitamin D as the primary immune regulating therapy and systematically taper conventional medications as remission is achieved. Our clinical data shows that in 97% of cases, we are able to immunomodulate and achieve remission of disease activity above 90% within the first 3 to 5 months using our methods. We begin tapering biologics, steroids, and immunosuppressants within the first 25 days of the protocol. Our target is to discontinue all biologics, steroids, immunosuppressants, and painkillers within the first 45 to 60 days. This is possible because we are restoring immune regulation, not just suppressing inflammation. When Tregs are restored, when Th17 dominance is corrected, when VDR-mediated genomic regulation of immune function is re-established, the need for pharmaceutical immunosuppression decreases dramatically. Some patients need low-dose methotrexate as maintenance. Most don't need any conventional immunosuppression once terrain is restored. Step 5. Lifelong maintenance. This is not a cure. This is sustained remission through continued metabolic optimization. Just as a diabetic may need lifelong insulin or metformin, RA patients with vitamin D resistance and genetic susceptibility need lifelong vitamin D therapy at therapeutic levels. But the doses can often be reduced once remission is established. The cofactor requirements decrease and the patient is off biologics, off steroids, off the medications that carry significant long-term risks. They are maintaining remission through physiological restoration of immune regulation, not pharmacological suppression of immune function. That is the difference. Pillar 3 is gut restoration. The gut is where RA begins for many patients. We must address it. We eliminate triggers by removing refined wheat and switching to millets, eliminating processed foods and refined seed oils and switching to cold-pressed oils, removing known inflammatory foods specific to patients' sensitivities, and in our Indian context, avoiding eggplant, cauliflower, prawns, and thorny fish. We also avoid liquid milk, though milk products like curd and ghee are okay. We restore digestive function by correcting hypochlorhydria if present. Many RA patients are on PPIs long term, supporting pancreatic enzyme function and optimizing bile flow. We restore gut barrier with L-glutamine supplementation, zinc carnosine, colostrum in selected cases, and properly prepared bone broth. We restore microbiome with high-potency multi-strain probiotics, prebiotic fibers, fermented foods if tolerated, and targeted antimicrobials if SIBO or dysbiosis is detected. We optimize eating patterns with 3 properly cooked meals per day and nothing in between. A minimum 4.5-hour gap between meals, chewing each morsel 25 to 30 times, which is critical for enzyme mixing, and drinking water only when needed in small sips, swishing with saliva first. This is not fad diet advice. This is systematic restoration of gut function to reduce antigen exposure and immune activation. Pillar 4 is infection clearance. We don't spend time and money identifying which specific fungal organism, which bacterial strain, which parasitic species is present. We treat everything. Our gut cleansing protocol is a cyclical protocol using antibacterial agents, antiviral agents, anti-protozoal agents, anti-helminthic agents for parasites, and antifungal agents. This comprehensive approach clears the chronic infectious burden that's driving immune activation. We also restore gut microbiome using probiotics. We find Saccharomyces boulardii particularly beneficial for re-establishing healthy gut flora after infection clearance. This protocol is cycled to avoid resistance and ensure complete clearance of chronic colonization. For periodontal disease, we coordinate with dentists for aggressive local treatment combined with systemic antimicrobial therapy when needed. This pillar is essential because chronic infections perpetuate immune dysregulation. You cannot achieve sustained remission while your immune system is constantly fighting low-grade infections. Pillar 5 is thyroid optimization. If thyroid dysfunction is present, we optimize it. For subclinical hypothyroidism with positive antibodies, We don't wait for TSH to reach 4.5 or 5.0. We treat when TSH is above 2.5 with symptoms. Target TSH is 1.0 to 2.0, free T4 in upper half of range, free T3 above 3.0. Thyroid hormone replacement is usually levothyroxine, dose titrated to target. Some patients need T3 supplementation if conversion is impaired. We monitor TSH, free T4, free T3 every 6 to 8 weeks until stable. For Hashimoto's management, selenium supplementation reduces anti-TPO antibodies. We address gut permeability and food sensitivities. Vitamin D optimization helps reduce thyroid antibodies. Optimizing thyroid function improves energy, reduces inflammation, and enhances immune regulation. It's an essential component of comprehensive RA management. Pillar 6 is metabolic correction. If insulin resistance and metabolic syndrome are present, we address them. For insulin resistance, we use a low glycemic diet emphasizing whole foods. Remove refined carbohydrates and sugars. Use time-restricted eating such as 16-8 or similar. Add metformin if HOMA-IR is above 3.0 and patient is not already on it for RA. Consider berberine or alpha-lipoic acid as adjuncts. And emphasize exercise, especially resistance training. For lipid management, we optimize omega-3 to omega-6 ratio, add fish oil supplementation, consider niacin if triglycerides remain elevated, and add statins if cardiovascular risk is high. Most RA patients qualify. Correcting metabolic dysfunction reduces systemic inflammation, improves medication response, and reduces cardiovascular risk. Pillar 7 is lifestyle and stress management. Breathing is not 20 minutes of pranayama daily. It's diaphragmatic breathing all day long. Light, slow, deep breaths to lower lobes. Activating parasympathetic nervous system. Reducing cortisol. Improving gut motility. Enhancing nutrient absorption. Sleep optimization means optimizing sleep quality and duration. Sleep is when tissue repair occurs, when immune regulation is restored. This involves sleep hygiene, melatonin if needed, magnesium before bed, and treating sleep apnea if present. It's common in RA patients. Stress management addresses chronic stress that drives cortisol dysregulation, which worsens immune dysfunction. This involves meditation or mindfulness practice, gentle yoga, not aggressive, counseling if needed, and social support networks. Exercise means low-impact exercise that maintains joint mobility, reduces stiffness, and improves metabolic function. Walking, swimming, cycling, gentle yoga, tai chi. Avoid high-impact activities during active inflammation. Patients always ask, how long before I see improvement? Honest answer based on our clinical data. First month, cofactor correction, vitamin D loading, gut protocol implementation, infection clearance initiated. Most patients don't feel dramatically better yet. Some notice improved energy from thyroid or B12 optimization. This is the foundation building phase. The biochemistry is shifting, but you may not feel it yet. 3 months. This is when vitamin D optimization starts showing clinical benefit. Typical observations include reduced morning stiffness duration from 2 hours to 30 minutes, improved grip strength, less fatigue, fewer flares. You start to notice I'm having more good days than bad days. 6 months, significant clinical improvement in most patients. Disease activity scores drop. Many patients can reduce DMARD doses. Some can stop biologics. Inflammatory markers improve. This is when patients often say, I feel like I'm getting my life back. 8 to 10 months. Our clinical data shows remission achieved in most compliant RA cases. Disease activity consistently low. Medications reduced or eliminated. Quality of life significantly improved. 12 months. For cases with compliance challenges or more severe baseline disease, this is typically when remission is achieved. This is not overnight. Immune remodeling takes time. You didn't develop RA in a week, you won't reverse it in a week. But the results, when achieved through terrain restoration rather than just suppression, are more durable. This isn't remission that disappears when you stop medication. This is remission maintained by restored immune function. We understand the impatience. When you're in pain, when you're exhausted, when you can't open a jar or button your shirt, you want relief now. But lasting relief, true remission, requires patience, consistency, and trust in the process. The patients who follow the protocol completely, who don't skip doses, who don't cheat on diet, who show up for monitoring, they achieve remission every single time. Before we discuss practical implementation, we need to be absolutely clear about something. Everything you've learned in this video, the vitamin D dosing protocols, the cofactor requirements, the infection clearance strategies, the medication tapering timeline, requires medical supervision. This is not a supplement routine you can piece together from online shopping. This is not a diet plan you can follow from YouTube videos. This is a clinically monitored therapeutic protocol that requires comprehensive baseline blood work analysis, individualized dose calculations based on your specific biochemistry, regular monitoring for safety including ionized calcium, PTH and kidney function, systematic assessment of disease activity and response, proper coordination with your existing treatment team, and adjustments based on real-time lab results and clinical response. We appreciate every comment and question we receive on our videos. Truly, we do. But we will not and cannot provide specific dosing recommendations, product suggestions, or treatment advice through comments, messages, or generic responses. Why? Because we are doctors, not influencers. Every patient's vitamin D resistance is different. Every patient's cofactor needs are different. Every patient's medication tapering timeline must be individualized. What works safely for a 55-kilogram woman with mild disease is completely different from what's needed for a 95-kilogram man with severe disease and kidney compromise. Giving generic advice without seeing your blood work would be medically irresponsible and potentially dangerous. If you want this approach for your health, schedule a proper consultation, in person or online. Bring your complete medical history and current medications. Get the comprehensive lab panel we've outlined. Work with our team or a physician trained in these protocols. Commit to regular monitoring and follow-up. We consult with patients all across the world. Geography is not a barrier, but proper medical supervision is non-negotiable. Your health deserves more than YouTube comments and generic supplement advice. It deserves comprehensive biochemical assessment and individualized medical care. In this part, we covered the complete implementation guide. How to start, what to expect month by month, and the personal story behind why Cure for Pain exists. But this is just one piece of a 2-hour masterclass that covers everything. The molecular science of RA, the blood work your rheumatologist may be missing, and the complete 7-pillar protocol. And why rheumatoid arthritis is actually the easiest autoimmune condition to bring to sustained remission. And if you want the complete picture, the full 2-hour RA masterclass is linked in the description below and pinned in the comments.